Okay, good morning. I'm Abby Nolder. I'm a pediatric otolaryngologist in Little Rock, Arkansas at University of Arkansas for Medical Sciences and Arkansas Children's Hospital. I'm also the program director for our residency program there. So I understand what you all are going through, and I'm very pleased to give this lecture today. When this pandemic started and the ENT community came together with all of these educational opportunities, I think it really speaks to our specialty and how great it is to be an ENT. So just scrolling through the list of the lectures that have already been done here, the expertise is incredible, and just the variety of lectures that you guys are able to access has been great through this. So I'm pleased to just be a part of that. So I'm going to talk today about pediatric tongue and lip tie. I'm going to talk a lot about the consensus statement that was released by or in the White Journal, the journal of the AAO-HNS, that was released in April. And it's something that I see a lot in my practice as a pediatric otolaryngologist, and anyone going into any general ENT practice, and certainly pediatric ENT, you're going to see this. And it's not that simple. You'll see the procedure, if you've ever seen or done one, is very easy, but determining who needs the procedure and when that should be done is a little bit complicated. And there are a lot of controversies. People are divided into, believers or non-believers in tongue and lip tie. So kind of the philosophy that you use going into treating those kind of depends on your education about it. And I think it's important to know about it and know how to manage these patients. So, okay, so I gave a lecture on this back in 2016, actually to our neonatology group, because the neonatologists in the nursery were seeing a lot of kids with tongue tie and difficulty breastfeeding, and they wanted to learn a little bit more about it and actually learn how to do the procedure in the nursery rather than sending them home and having them come back to ENT. So in doing that and preparing that lecture, I did a little Google search. So this was 2016, just searched for tongue tie on Google. And the main hits were, let's see, this tonguetie.net, this information for parents and practitioners, Breastfeeding USA, some stuff from Mayo Clinic. But there was about 887,000 results. That was in 2016. So I repeated that to do this, to update the talk, and now there are 182 million results if you type in tongue tie into Google. And that kind of reflects what we've seen as otolaryngologists, is that the popularity, if you will, of tongue and lip tie, whether it's increased recognition or just increased interest, and we'll talk a little bit about where that comes from, but there are a lot of people looking and writing and blogging about tongue and lip tie. So again, this is why it's important for you to know about it, because they're going to show up into your office, whether they get referred from their pediatrician, from the nursery, from lactation consultant, or just parents, moms getting together talking about oh, well, my kid had a lip tie and a tongue tie and had it fixed or whatever. These kids are going to come and see you, and it's a really kind of hot topic, popular topic, at least right now. So tongue tie, ankyloglossia is the other term for it you may have heard. So incidence ranges from 2.8 to 10%. So previously, like when I did this talk a few years ago, that incidence was 2 to 4%. So the incidence has gone up. Has it really gone up, or are we just, recognizing it more and seeing it more? It does have a male predominance, about 2 to 1, and I would definitely say that I see that in my practice. I see far more male infants coming in for tongue tie than I do females. So frenotomy was common at birth in the 18th and 19th century. You may have heard of midwives keeping one fingernail long. They could release the tongue tie immediately after birth. But it kind of fell out of favor when breastfeeding, when formula and bottle feeding became more accepted. Frenotomy became less important because, as we'll see, tongue tie, the biggest problem that tongue tie causes in infants is difficulty breastfeeding, whether that's a difficult with the latch, difficult expressing the milk during nursing, or a painful latch for the mother. But over the last several years, we've seen kind of this push more back toward breastfeeding. Breast is best, breastfeed your infant. Nurseries, hospitals are kind of pushing this for mothers to breastfeed their infants. So it's come back kind of into favor. There's also been an increased awareness of the effects of tongue and lip tie on breastfeeding. Like I mentioned, literally blogs, Facebook pages, there are support groups for, women taking care of their babies with tongue and lip tie, lactation consultants. So along with the push for breastfeeding in nurseries, the moms are getting lactation consultant referrals who are, monitoring those kids and seeing that they're having tongue and lip tie, and then referring them to a surgeon to get them fixed. I mentioned the social media websites, blogs. And then there's also more practitioners treating ankyloglossia. So I mentioned our, pediatricians in the nursery, local pediatricians. There's also been kind of a resurgence in dentists treating tongue and lip tie, and we'll talk about that a little bit more. They actually use a different modality than we do in ENT, but again, there are people out in the community that are offering this, and the parents are aware of that. So all of that put together, there seems to be an increased number of patients being diagnosed with ankyloglossia. And if you see the picture over on the screen, this is actually taken directly from the clinical consensus statement from the AEO, the white journal. And you can see just the anterior ankyloglossia. We'll talk about kind of definitions here in just a minute. But this frenulum here, where it attaches at the tip of the tongue to the lower part of the alveolar ridge there, and it prevents the tongue from protruding, but also prevents it from elevating. And then this is more of like what we call a posterior tongue tie, which is also controversial. We'll talk about that in a minute. So lip and buccal ties. This gets a little bit more complicated. You see the picture over here on the right. So the upper lip has a frenulum, just like the tongue, where it attaches from the lip to the upper alveolus. And this picture here was taken from drgahiri.com. So Dr. Gahiri is an otolaryngologist. He did his training in Ohio, at Ohio State, I believe. But he's kind of dedicated his practice to management of kids with tongue and lip tie. And he's got a website that has a lot of information, some instructional videos. But this is taken from his website. You can see how the frenulum there that's attaching. The thinking is that it prevents the lip from everting during feeding. And then buccal ties. So this is even more controversial. I was able to find this picture on a breastfeeding website, Breastfeeding Medicine of Arizona. And you can see these little bands of tissue basically on the inside of the cheeks attaching from the cheek to the maxilla. So we'll see in the clinical consensus statement that really there's just not a lot known about buccal ties and whether or not they affect feeding at all, or whether or not they should be surgically addressed. I'll tell you, in my practice, I've never seen one, I've never treated one, and it's pretty controversial as to whether or not they even need to be treated. Okay, so why is it controversial? Well, some people don't even agree on the definition of a tongue and lip tie. And it gets kind of difficult when a baby comes in. I mean, those first pictures that I showed you where the frenulum is attached at the tip of the tongue, the baby can't stick their tongue out at all. That's relatively easy to look and see, yes, that's a tongue tie, but some of them are not that easy. Is it an anterior tongue tie versus posterior tongue tie? Some people don't even believe that posterior tongue tie exists. If you look in there and there's no significant limitation of the tongue from the frenulum, and people, you get referred from a lactation consultant saying it's a posterior tongue tie, and you look in there and there's nothing there, it's kind of hard to justify clipping it. What is the severity? How can you look at one frenulum that looks the same as the next and say, this baby is feeding worse than the other? So how do we classify it? The consensus statement, they were not able to reach consensus on what classification or grading system should be used for evaluating tongue tie and lip tie. There are different classification systems, the Correlose classification, that just basically looks at where does the frenulum attach, versus more of these functional assessment tools, the Hazel-Baker and the Bristol tongue assessment tools. Both use kind of the anatomic and functional considerations. What is the significance of it? And I'll explain a little bit later. In my practice, the main driver for treating it is how motivated the mom is to continue breastfeeding the child. Because again, in an infant with tongue and lip tie, the main issue that it's going to cause is with breastfeeding. So, but we also know that even if you don't do anything, some of these babies will continue to do well and do fine. And if they transition to bottle feeding, they're probably going to be fine. So, if we don't do it, what's the impact on them as they grow? And I get parents that ask me that too. They're like, if I don't do this now, is this going to cause problems later? Because I've read that it can cause speech problems or, difficulty with eating. So, what's the significance of it and what's the long-term impact? Treatment, do you do medical treatment, which really, other than, positioning, working with lactation consultant, those kind of things, those are the main medical treatments. Or do you, do the surgical treatment, which is release of the frenulum, which we can talk about different ways of doing that. And then I mentioned, there's these kids are coming to our clinics kind of at an increased rate. This was an article that was released in the Atlantic that kind of caused some buzz in March of 2019. So why so many babies are getting their tongues clipped. So now that all of these, it's become more popular, now people are looking at it and thinking, okay, is this really necessary? Are we doing these procedures on these babies that aren't needed? This article down below there, the tongue tie and lip tie epidemic in America. Dr. Way is a pediatric otolaryngologist at Nemours. But we're all seeing this. The question is, should it be done? Does it help? Are we doing it too frequently? All of those considerations. So in April of 2020, despite a global pandemic, this clinical consensus statement on Ankyloglossia in children was released in the White Journal. So this is made up of multiple pediatric otolaryngologists across the country, all experts in their fields. And a little bit about, so this is a clinical consensus statement, not a clinical practice guideline. So what's the difference? So a clinical consensus statement reflects opinions drafted by content experts for which consensus is sought using explicit methodology to identify areas of agreement and disagreement. So it doesn't really give you a guideline for practice. It's just basically an expert opinion. And clinical consensus statements are used when the literature on a specific topic is not, we don't have a lot of high level evidence to actually form a guideline. So that's where this consensus statement came from. They basically sent surveys, this panel of pediatric otolaryngologists. They sent surveys on different statements regarding management of tongue and lip tie and decided whether or not they were able to reach consensus on each statement. So what they were able to reach consensus on is the definition of ankyloglossia. So they define that as a condition of limited tongue mobility caused by a restrictive lingual frenulum. You can see here, this is what we call an anterior ankyloglossia. Again, this is an older child because child has teeth, but you can see the frenulum there attached to the tip of the tongue down to the alveolus here. And again here, so it's well agreed upon that when the frenulum attaches at the front of the tongue to the alveolar ridge, that is, ankyloglossia, that is tongue tie. Where it gets a little bit more murky, like I mentioned, is the posterior ankyloglossia. So there was actually no consensus reached here. You can see a small frenulum here in this picture, but again, it's clearly not as restricted as you can see in these. So, and then if you see this baby here, there's really, you can't even really see a frenulum at all. So, when this child comes in and the mom is complaining of, baby having a difficult latch or painful latch, and you look under the tongue and there's literally no frenulum there, that's when it gets a little bit more difficult in deciding how and if to manage that patient. So in the clinical consensus statement, they were not able to really reach a consensus on either the definition or the management of posterior ankyloglossia. So how do we evaluate these patients? So one thing that was agreed upon in the consensus statement, they refer to the mother and the breastfeeding child as a dyad. So the maternal infant breastfeeding dyad should be recognized as a vulnerable patient population, and that care should be taken to ensure adequate support services, education and counseling, and shared decision-making. So I will tell you, just as a practicing otolaryngologist, these moms that come in with these babies, especially if they're, newborns, just a few weeks old, they've been struggling at home, they're sleep deprived, they're, trying to feed this baby and it's painful and it's difficult. They are often at their wits' end and will come in literally in tears, about these babies. And so, they deserve our respect, they deserve our, compassion and sympathy, and not just, passing it off as, oh, this is overblown, your baby doesn't have a tongue tie, so you have to really kind of recognize where they're coming from and use that, in guiding your treatment. And then, education and support. So in our clinic at our hospital, we are fortunate to have speech language pathologists that will actually come in and, watch the infant feed, whether it's, breastfeeding or bottle feeding, and really do an assessment while they're in the office to tell us, yes, I think that the tongue, the tongue tie or the lip tie is interfering with feeding. So it is really recommended that either the mom have a lactation consultant see them, or a speech language pathologist, or sometimes both would be really helpful. And then the shared decision making. I mean, what I always tell them is that, this could be part of the problem with the breastfeeding, but there's always the possibility that it won't fix it. So you always have to set those expectations to make sure that no one is disappointed at the end of the visit. So you want to take a good history. Certainly, it would be important to know if the baby was born premature, or if there are any other, breathing difficulties or feeding difficulties that may be affecting your management. You want to do a full exam. You want to look at the entire, do your full head and neck exam, because there may be something else going on that's affecting the baby's feeding. And again, the feeding evaluation, either a speech language pathologist or a lactation consultant. And most kids, they will have, or moms will have been seen by a lactation consultant in the nursery if they were having trouble, nursing the baby before they were discharged. So what are some of this, the most common thing that a mom would come in complaining about in a baby with a tongue tie is that the latch is very painful. And the reason for that, and you can see these pictures over on the side. So to be able to express milk from the breast while the baby's nursing, they have to be able to extend their tongue, cup it, and then elevate the tongue to the roof of the mouth to help express the milk. And the tongue tie actually prevents not just the anterior movement, but the actual elevation of the tongue to the roof of the mouth. And so what they'll get is just a very painful, shallow latch. They may lose the latch. They're not able to sustain it. So that leads to inefficient feeding. They may spend 30 minutes during a feeding session, but the baby's just not able to get enough milk. They may be losing weight. They may have had to start supplementing formula. And for some moms, that's really a stressful thing if they're wanting to completely breastfeed their baby, if they're having to, pump and do bottle feeding or, switch to formula. That can be distressing. Another thing that they may complain about is an audible swallow or clicking. And that is just, again, that they're just not able to get an efficient latch. So they're swallowing a lot of air sometimes, and that'll cause kind of a clicking sound. They may be losing milk out of the front of their mouth because they're not able to get that nice seal and latch. Reflux. So if you look on some of these websites and blogs, people say that, tongue tie can cause reflux. Well, does it? All babies have reflux to some extent. But I think what it could cause is that if they're not able to get a good latch, and this is for both breastfeeding and for bottle feeding, if they're swallowing a lot of extra air, then that's going to make them a little bit more, colicky, if you will, or maybe kind of make their reflux symptoms worse. So it's not that the tongue tie causes reflux, it just causes some difficulties in feeding that may lead to reflux symptoms. So it's also, I mentioned that doing a full head and neck exam is important to evaluate for other etiologies of breastfeeding problems. So a lot of times I'll have a child come in for evaluation of tongue tie, and I note that they have stridor, and they end up, I do a scope or whatever to evaluate, and they end up having laryngomalacia. Prematurity is an important one. I mean, a premature baby is going to often have difficulty feeding, but may or may not be related at all to the tongue. Are there any neurologic or cardiovascular disorders? Is the baby hypotonic? Infants born to diabetic mothers will sometimes be a little bit more hypotonic and a little bit more difficult feeders. Do they have any cardiovascular disorders? Obviously, if you have a heart problem, then that's going to cause some inefficiencies in feeding. Is there any nasal obstruction? Obviously, choanal atresia, congenital piriform aperture stenosis, anything that causes the baby difficulty breathing through the nose is going to cause difficulty breastfeeding. Rhinitis of infancy, which is basically a term that we use for babies that are obligate nasal breathers. If they have any nasal congestion, it's going to make it more difficult for them to feed. Any other airway obstruction? I already mentioned stridor from laryngomalacia. Is there any vocal cord paralysis? I know the baby could be born with bilateral vocal cord paralysis, which would lead to difficulty feeding. Craniofacial abnormalities, retrognathia, micrognathia, Pierrot band sequence. Does the baby have a cleft palate? You certainly wouldn't want a child to leave your office without being diagnosed with one of these things if that is what is causing the feeding problems. Again, so when you're evaluating them, and especially if you're considering doing a frenotomy, you really want to clarify the indications for it. Baby comes in with complaint of difficulty feeding. What are the diagnostic criteria? Again, those are a little bit up in the air, but you really want to examine the baby, let the mom know, what you're seeing, and then set expectations. Especially, if you suspect that the child has some other airway anomaly or a neurologic problem or hypotonia, the expectations for completely fixing the feeding problem are going to be different than a child that has no other findings on exam. You want to limit over treatment. I mean, you're not just going to, clip every tongue that walks into the office, but you also don't want to delay treatment. in those infants that would really benefit. So you really, there's no consensus on the age to treat, but essentially the sooner the better, because the longer the child goes, if there's a significant tongue tie that is impeding breastfeeding, the longer that goes without being treated, the more likely that the mom is going to just stop breastfeeding altogether, and you're going to kind of miss that window of opportunity to make it better. Again, the desire to continue breastfeeding is often the driver for treatment. So I will ask the mom, is this your goal to continue breastfeeding, especially in the child that has what I would consider maybe a mild tie, where they're able to get the tongue out. It's not significantly restricted, and I don't think it's going to cause any problems down the road. But if the mom is really motivated to continue breastfeeding, then I'll go ahead and offer frenotomy for that child. But again, no consensus on age to treat. I usually, in my practice, for doing in-office frenotomy, I usually say 3 months or less. I have kind of stretched that a little bit depending on the child. Like if it's a ex-preemie who is maybe 4 to 6 months old and a little bit on the smaller side, has a thin frenulum, I have no problem addressing that in the clinic. Once they get a little bit older, I'd say 7+ months, they start getting teeth, and it's really difficult to kind of hold that child down, get the mouth open, clip the tongue. It makes a mess. The parents freak out. Everybody freaks out. So the younger the better to do those in the office. And then the older kids, I do offer general anesthesia for that. So how do you examine these children? So this is a picture from Dr. Gahiri's website. And this is how I do mine also. I kind of get the mom to hold the baby in her lap with the head toward me, and kind of go from the top, and I'll lift the tongue up with my fingers, kind of get it between the fingers and lift up. And what that does is really, retract the frenulum and allows me to see kind of how restricted it is. And I do that both for the tongue and the lip. I'll lift the lip up and see if there's a restriction from a maxillary frenulum. And then the picture over on the right is using 2 Q-tips or cotton tip applicators. I use these a lot in my procedure as well. I'll show you that I use. They work really well to retract, and it also helps you kind of see, if you first just look in the mouth, you may not think that there's much restriction, but then when you retract on either side, you can actually see that there's a frenulum there that is restricting that elevation of the tongue. So once you've done your evaluation and you say, decide, yes, this child would benefit from frenotomy, again, you want to set your expectations. Part of the consent process is to, let the mom know, especially if you're doing it in the office, you don't have any considerations for general anesthesia or anything. So the biggest risk is, hey, I may do this and it may not improve your breastfeeding at all. It may not eliminate the painful latch. If there's something else going on, it may not completely fix everything. There is a risk of bleeding. I always tell the parents that usually just applying pressure is enough to stop the bleeding, but every now and then I do have to use some silver nitrate. It's very rare that they would bleed beyond, just the 5 minutes that they're in the office, but potentially that's a risk. Injury to salivary structures, the Wharton's ducts, so the submandibular ducts are right just inferior to the frenulum, so theoretically you could injure those and cause problems there. Oral aversion, I've never had a child have that, but when you're doing a procedure in the mouth, it may cause pain or some discomfort that would make them not want to eat. Scarring, it's very rare that I've actually never had to revise one, but I mean, it's going to scar to some extent, but it's very rare that it would cause, any long-term difficulty. And then again, need for repeat frenotomy. So again, I've not had to revise one. I will say that I've had, babies come in or kids come in whose parents said that they did have to have it done twice, but that's not happened to me personally. Okay, so if you're doing this in the office, you're going to get consent, do a timeout just like you always would. A little bit of controversy as to whether or not to use anesthetic. I usually, if I'm doing a lip, I do inject those with 1% lidocaine with 1 to 100,000 epi, both for the pain, because I mean, the frenulum is much thicker. You're doing right on the gingiva, so I think it's painful, and I do it for the hemostasis. But for an infant, for doing just the tongue frenotomy, I do not inject local anesthetic. I do sometimes use a little bit of topical viscous lidocaine. The problem with using topical anesthetics in infants is that you can't really figure out the dose that you're giving. And they mentioned this in the clinical consensus statement, specifically with benzocaine. You don't really know how much is being absorbed, and it's really hard to control for that. So the clinical consensus statement, they actually said that anesthetic is not recommended and not needed, but they do recommend using oral sucrose, which they use a lot in the nurseries and NICUs. You basically put a little bit of sugar water either on a gloved finger or on the pacifier, and you have the baby suck on that, and it actually has pain relieving and soothing properties. I think it releases dopamine or something that similar to help them manage pain. So I do actually use that. Plus or minus clamping. So if I do a lip frenulum, I will clamp the frenulum first, and the whole point of that is to when you clamp the tissue, it helps you with hemostasis. I've found with the tongue that clipping is not necessary, and it's just one extra step that is just as easy to elevate and clip with scissors without clamping. And then I think blunt dissection is important. So once I've clipped the frenulum, I'll take my finger with a 4x4 or take one of the cotton tip applicators and kind of press and gently dissect until I get the full release. And it should look like a diamond when you're done, and I'll show you a picture of that. That's when you know that you've gotten full release. And then I usually hold pressure. Again, I found that direct pressure with the cotton tip applicator is the best way to stop the bleeding. I used to use just my finger with a 4x4, but these are little infants, and they're moving around, and you're pushing their tongue back, and they're it can get kind of crazy. So I think just a cotton tip applicator, direct pressure on there. It takes literally, if you hold pressure for 30 seconds to a minute, it's going to stop in most cases. If not, then I do use silver nitrate. I always warn the parents that if I do use silver nitrate, it kind of, it looks a little bit more messy. If you've ever used it in the nose, which I'm sure most of you have, it kind of runs a little bit and looks gray and white. So I always tell the parents ahead of time that to expect that it's going to look a little bit weird in there. And then I let them start feeding right away. So I usually have the mom still in the room, and I'll just give the baby right back to them, and they can either, bottle feeding if they're bottle, or they can start nursing the baby right away. And especially the young infants, within a month, if they're a month or 2 old, they cry literally for the time that you have them, on the papoose board. But once you hand them over and they start feeding, they're totally fine. And the parents, they feel good that, they did something right, and the baby can go back to feeding right away. So this is my setup. So I mentioned the cotton tip applicators. I usually have at least probably 4 of those, because I use them both to retract and hold pressure. This is that oral sugar water stuff, oral sucrose. It's called Sweeties, or whatever you have in your office. But if the baby takes a pacifier, then my nurse, who's assisting, she'll put a little bit of that on the pacifier. Or if the baby is not using a pacifier, she'll just put it on the finger with a glove and have the baby start sucking on that before we actually do the procedure. This is viscous lidocaine. Like I said, I honestly have kind of moved away from using that, because I really haven't found, anecdotally, that there's really any difference in the infants that I use lidocaine on and those that I don't. Some of the parents kind of get freaked out if you tell them they're going to do them without any anesthetic. And so if that's the case, I'll put a little bit on a Q-tip and, just dab it under the tongue and let that sit for a few minutes before we do it. Again, I have the silver nitrate ready. This is called a grooved retractor. Some people call it Mickey Mouse because it looks like Mickey Mouse ears. It's actually a retractor they use for hernia repairs, but I found it's really, really nice for doing frenotomy because you can just put it under the tongue and it really elevates and gets the frenulum in the center there so you can release it. If you don't have one of these, pickups is totally fine. Just put the tines on either side of the frenulum and lift up, and that's going to give you the retraction that you need. And then scissors. I'll usually use like a curved iris scissor. You can use straight. It really doesn't matter. Just some sort of small, sharp scissor. And then obviously 4x4s. Some babies will, I'll have suction available too, because some kids, if they have a lot of secretions and then you've got bleeding and then, they're laying there on their back and it kind of gets messy. So you also probably want to have some suction available. So again, how I do it, here's a picture of the grooved retractor there. Again, this is an older child because it has teeth, but so the little groove goes on either side of the frenulum. You lift up, it really retracts, and you use your scissor to divide the frenulum. So this is where the diamond shape, so you really, if you just release the frenulum down to the tongue without getting this diamond shape, there is still potentially some tethering that could prevent the elevation. So you don't want to go all the way into the muscle because then that just bleeds, and you don't want that, but you want it released enough to where it releases on all sides and forms this little diamond. And this is where I think the blunt dissection really comes in handy, especially in an infant. These tissues are very thin and you don't need to use a lot of pressure or force, but you can use your scissor to get down to release it, and then just use either, a finger with a 4x4 or the cotton tip applicator to kind of spread and push, and it dissects it and it looks just like that, and it's very minimal bleeding, and then you know that you're done. And then if you hold pressure for a few seconds or up to a minute and it stops, you turn them back over to the mom and life is good. And if not, you can touch it up with silver nitrate. So again, you want it to have this diamond, and this is whether you're doing it in the office or if you're doing it in the operating room with cautery, same thing. I do the cautery method the exact same. I do, if I have them in the operating room, I do inject local just because, I think it kind of helps with the, post-op care. But again, you would just use scissors or Bovie if you're in the operating room and do that blunt dissection and end up with this diamond shape. So one of the things that was discussed in the consensus statement is, what is best? I mentioned cautery. If I do it in the operating room, I usually use cautery just because it's faster and it's not going to bleed. I don't have to hold pressure. I've got that available to me. If I'm in the office, I use scissors just because it's a younger child. I don't want to, deal with setting up the Bovie and all of that. Some people advocate for using a laser, and we'll see this a lot in our dental colleagues. They'll use a laser. This is taken from this BioLase website using something called a water laser. And I put this picture here because there's a lot going on here. This handpiece is kind of big and this baby's mouth is really small and they've got the goggles on, and I don't know, it just seems like a lot to do when I can take scissors and do it in like 2 seconds. So I choose not to use a laser. Dr. Gahiri that I mentioned, he actually does have a laser in his office. The consensus was that there's really not one method that's better than the other. It's whatever you have at your disposal and what works for you. But I feel like, the cost of the laser, you can't, I guess you could have the parent in the room, but then everybody has to wear eye protection, and there's just all the extra precautions you have to use to use a laser. So I prefer either just cold technique with scissor, or from the operating room, I'll use cautery. And some of my partners, we do have a little small cautery unit in our office, and they will use the cautery in office for frenotomy. But none of us currently in our practice are using lasers for frenotomies. What's the aftercare? Not much. I mean, I just give the baby back over to the mom, let them feed. There is, depending on what you read, some people will advocate doing stretching exercises. What does that mean? I'm not sure. I do tell them to kind of use, take the finger and, or take, parent's finger and kind of press under the tongue, and, theoretically that would, prevent scar tissue from building up and whatnot. But again, there's not much literature out there on that. I do mention it just because if they go and read about frenotomy, that's going to come up, but I don't have any, special, magic sauce for that. I just tell them, yeah, do some massage, after a week or two. Tylenol is usually enough. If it's an older child, 6 months or older, they can have ibuprofen, but there's really not much care involved, and they really don't have much pain afterwards. So what about, this talk would not be complete without one mention of COVID-19. So ASPO, the American Society of Pediatric Otolaryngology, recently released a statement on use of personal protective equipment for aerosol generating procedures. So that's the big question now, is like, what is an aerosol generating procedure? We in our practice, they define it, or actually CMS defines it as any procedure on the mucous membrane, including the respiratory tract, with a higher risk of aerosol transmission. So we consider in our office a frenotomy to be an aerosol generating procedure. So we are using N95s, face shields, gown, and gloves for those procedures. If it's something that's done in the operating room, if that child's being treated in the operating room, they will have had a COVID test. And then we're using our discretion as to whether or not to wear an N95. But I think most people would agree that during this COVID era, that if you're doing a frenotomy in the office and the COVID status is unknown, that it's recommended to use full PPE, including N95. I do want to mention too, before we move on, the maxillary, the lip tie, and I'm going to talk about that briefly in a minute, but the instrumentation that I use is essentially the same. I did say that I will clamp first and then cut, but the procedure is basically the same. You lift the lip, clamp, and then release it with scissors. I do find that I use silver nitrate pretty much 100% of the time if I'm releasing a lip tie in clinic, because it does bleed a lot more. You're right on the gingiva. But I found, again, that just some local pressure with the cotton tip applicator and then one touch of silver nitrate, and that's all it usually takes to get it to stop bleeding. So I did want to mention I will also do those in the office. My age threshold is a little bit lower, but I'll still do it up to about 3 months in the office. I just prepare, the family that it's going to bleed a little bit more than just releasing the tongue tie. Okay, so what about tongue tie in older children? This is where it gets really, really gray, because there's very limited evidence and low quality evidence. It's just not been studied a whole lot. What about the bottle feeders? So again, I mentioned that my threshold for managing the tongue and lip tie in clinic often depends on whether or not the child wants to continue breastfeeding. Well, what if they're a bottle feeder? I honestly leave it up to the parents. I mean, I have personally a very low threshold for clipping, especially if I feel like there's any limitation at all. I will offer it. But again, you want to talk to them about, it's probably, once they stop bottle feeding, if it's very mild, they're probably never going to have a problem with it later on. So depending on the age and whether or not you can do it in the office versus taking them to surgery, I just really, leave that up to shared decision making between me and the parent on whether or not to do that. it is agreed upon, and this was discussed in the consensus statement, that, you know, if an older child has a really significant, especially anterior tongue tie, to the point where if they cannot get their tongue out past their lip, especially if it kind of causes a dimple there at the end or looks kind of heart-shaped, it is agreed upon that can cause some problems, both kind of socially and mechanically functional problems in the tongue. So literally, like, can't lick an ice cream cone or French kissing. I know that's weird, but like can't get their tongue stuck out, you know, past their lip. Talk about dental health. So we use our tongue to, you know, sweep food from side to side, but also to clear, you know, food from our teeth. So if you can't move your tongue and get full mobility, there's concern that you could have problems with, you know, keeping the teeth clean and oral hygiene. And then speech articulation. This is a little bit controversial, because even with a significant tongue tie, even, you know, the jury's still out on that. But again, if they're significantly restricted and are not able to, you know, get full mobility of the tongue, again, I'm pretty open to offering frenotomy to those kids. But again, there's not a lot of evidence. If it's a very mild tie and they are able to move, you know, the tongue freely, and they are able to get it out past their lip, then I really have a conversation with the family. You know, we can do this, but you know, it's probably not going to cause a problem for your child in the future. One other thing that I will mention, so because on these blogs and some of the things that we read about tongue tie, there's this question as to whether or not Ankyloglossia causes obstructive sleep apnea. And a lot of that comes from, I think, the dental literature. And I mean, it makes sense to think that if the tongue is, you know, tethered in, you know, in a position to where it could interfere with like palatal development, and then could potentially lead to mouth breathing and you know, problems with sleep apnea. But the consensus from our Academy consensus statement is it does not cause OSA. And in some ways, releasing it, if you think of, you know, if you were to release the tongue, then potentially it could, you know, fall back and contribute to OSA. So I am not releasing tongue ties to prevent nor treat obstructive sleep apnea. So I'll just leave it at that. Again, the lip tie, there is not much consensus here. The thinking is that when the baby is breastfeeding, if they're not able to get that lip to evert and kind of to get the latch, it can also cause painful latch similar to the tongue tie. Again, these, if I see that the baby is not able to get the lip up or everted during breastfeeding, and there is a frenulum there and the mom is really motivated, I will release it. Again, I don't have a lot of, I don't grade them or say, you know, this is a grade 1 or grade 4 lip tie. I just kind of look and see if it seems to be restricted and the mom is having problems, the baby's having trouble feeding, then I'll release it. Or if they've had if they've had a tongue tie and they've had a frenotomy and they're still having problems, then you can also address the lip to see if that will help. Again, I do them in the office if they're 3 months or younger. Over that, I'm usually advocating to do those in the operating room because of you know, being able to use cautery, and sometimes I'll need to place a little stitch to reapproximate the mucosa. So the older child, I will take them to the operating room. I get a lot of referrals for lip tie because the parents are worried because there's a space between the teeth. You can see this picture here where the frenulum's attaching between the teeth. So the thing here is that basically what I tell parents is that releasing the lip tie is not necessarily going to prevent the child from having a diastema or a space once they get their adult dentition. And the reason for that is well, often genetically determined, but the space between the teeth is more about the tension and the interdental ligaments and the different ways that the teeth are pulled. And none of that is really determined until the child has their permanent dentition. So usually if I have a parent come in and their main concern is the space between the teeth, I will talk to them about risks and benefits of releasing it, but I never go into it saying, okay, if we do this, the child is not going to have a space between the teeth. Because 100% of kids, when they get their baby teeth, they will have a small space. Usually as they grow and the maxilla comes down and they develop their adult teeth, they will not have a space. But again, releasing the tie is not going to prevent that. Some parents decide that they want to go forward with it and will do it, and I will offer it, especially if they're going to the operating room for something else. So they're, need ear tubes or something where they're going to be under general anesthesia. I have no problem releasing it. But again, I just talk to them about the risks and benefits and really make sure that we have good expectations and that we're doing it for the right reasons. But the consensus from the clinical consensus statement is that it is not indicated for prevention of diastema or the space in the permanent dentition, and I fully agree with that. Buccal ties, again, I have no idea. The consensus was that surgery should not be performed for buccal ties. There really is very little or no evidence that buccal ties even affect breastfeeding or would be a problem. Now, some breastfeeding advocates, buccal tie advocates, found that to be a little bit controversial. We just don't know, honestly. But I have yet to operate on one, and I'm not going to go looking for them. But so when parents come in and asking about buccal ties, I really tell them the truth and that I just really don't know. And as a otolaryngology community, we just don't know much about it, but probably not going to be doing a lot of surgical release of buccal ties. So in conclusion, basically, like I said at the beginning, I'm by no means a tongue and lip tie expert, but I've found that I do get a lot of referrals both within the hospital and outside. And I think because I just really listen to the parents and I let them, be involved in the decision making. I try not to dismiss it. A lot of people, when they see tongue and lip tie on their schedule, will kind of do a little eye roll because it's a little bit out there, especially the ones that are not totally obvious. But I do respect that relationship, especially with the breastfeeding infant and the mother, and just try to be compassionate and sympathetic to that, and treat them as I see fit. And a lot of them, even for, a small little thing makes a huge difference for them, and they're very thankful for that. So, but again, perform your exam, correlate with symptoms, look for anything else that may be contributing to the feeding problem. Speech consults are critical, both for the infant that's having feeding problems or for the older child. If there's some question that a tongue tie is causing articulation problems, the speech pathologist can be very helpful. Lactation consultants for the breastfeeding ones. Risk benefits, share decision making, manage expectations, just like you would with any other procedure. So that is all I have. I am happy to answer any questions that anybody might have. So like I mentioned, the clinical consensus statement released in April. I encourage you all to read it. It's got a lot of good information in there. It's available. You can get the PDF on the website, but for the White Journal, but it's really helpful. Has a lot of good information and good references. So